Endometriosis, in its simplest terms, is endometrial-like cells. The endometrial cells are what lines the lining of the uterus for women. That's where it should not be.
So it can land on the sidewalls of the pelvis, next to the ovaries, the intestines, the bladder, and that tissue releases a lot of inflammation and chemicals that can cause pain and can also build up and lead to scarring.
Every woman is different, so just like there can be different symptomatic presentations, the appearance of it in the pelvis can be highly variable. So some women may have superficial deposits along the surface of the lining of their organs in the pelvis, and other women may have cystic lesions in the ovaries called ovarian endometriomas.
It's been found on autopsy even in the lungs and the brain of women. So it's just cells that aren't where they're supposed to be. The hallmark of endometriosis is usually painful menstrual cycles, but we know from taking care of these women that they can have just a conglomerate of other syndromes. It could be pain in other times of the month. It could be pains with other activities such as intercourse or bowel movements or using the restroom even, or they could have some silent symptoms like infertility, which we don't talk about very commonly as being associated with endometriosis.
Adolescents report more nausea accompanying their pain in comparison to adults. And it seems that adolescents and young adults more commonly experience pelvic pain outside of the period.
We know that it affects approximately 10% of reproductive age women, but really we believe that's an underestimate, and likely even more women are impacted by endometriosis.
Patients beyond menopause can still experience symptoms related to endometriosis and can still have ongoing pain symptoms.
On average, it takes about 7 to 10 years for women to even get diagnosed with endometriosis, though their symptoms began maybe even with their first menstrual cycle.
We can diagnose endometriosis through a procedure called laparoscopy, but we can also provide a diagnosis of endometriosis clinically, and that means the healthcare provider really needs to dive into the patient's history.
I've been working on an ultrasound protocol with a few additional maneuvers and areas that will help to identify common sites of endometriosis. That in combination with the clinical variables and having that understanding, the education piece, and having all of those clinical resources come together with our medical diagnostic tools will really be the next stage and forefront of things that are readily available to us that will help to accelerate that path to diagnosis.
So there are a lot of conditions that get mixed up in the diagnosis of endometriosis and will delay it. Some of the more prevalent ones are irritable bowel syndrome, PCOS, even though the hallmark of that is not necessarily pain, but some imaging abnormalities. Some patients will get diagnosed with pelvic inflammatory disease, which has a different chronicity and a different cyclical pain regimen than endometriosis. Some patients will be told that their fibroids are what's causing their pain. And what we have to realize and recognize is these can all live concurrently. They can all live together.
Even though there's no known genetic predisposition per se, we know it can run in families. These types of history details are really relevant.
I frequently have teenagers come in with their family members. However, sometimes it can be a barrier, and so I think it's crucial that we also interview the adolescent by themselves without a family member so we can facilitate open and honest communication, and the adolescent can disclose symptoms that they might feel uncomfortable disclosing with a parent or family member in the room.
The care team for women living with endometriosis really should be vast. It usually is not going to be one provider or one specialist. Their primary care doctor, who might be the first person they present with some type of concern. Again, they may see their GI doctor. They may go see their mental health specialist.
Endometriosis is a multidisciplinary disorder, and it really requires a multidisciplinary care team.
Sometimes a pain specialist is involved because adolescents might have other overlapping pain conditions. Our adolescent patients may also benefit from other specialists, including acupuncturists or pelvic floor physical therapists.
Improving long-term care with our patients as providers really starts with understanding that they are a part of that care process. They're a part of that care decision. They need to have a full understanding of what is going on with their body.
Really addressing the diagnosis itself is of key importance, especially after all of the delayed diagnosis that has occurred in the past, as well as then addressing the consequences of the disease when it occurs.
I think it's important for clinicians to know that endometriosis can really affect everyone. It can affect adolescents, even early age adolescents who might not have had years of periods. Endometriosis can affect all races, ethnicities, backgrounds.
If there are any symptoms that you're not able to explain in another manner, endometriosis is likely the answer. I see it so commonly in so many patients.
Understand that endometriosis is not just a diagnosis of pain, but it absolutely affects their entire life.